If you have signs of adrenal insufficiency, what is the diagnostic workup? So the first thing you're going to do is you're going to get a morning cortisol and ACTH level to determine if this is primary adrenal insufficiency versus central adrenal insufficiency. If your cortisol level is low but ACTH is high, you know it's primary. If cortisol is low and ACTH is also low, then you know it's central. And if it's central, remember that the mineralocorticoid symptoms are not going to be all that pronounced because mineralocorticoid is going to be controlled by the renin-angiotensin-aldosterone system. But over here, we're going to have mostly the cortisol symptoms and the androgen symptoms, particularly in females. In males, remember that the androgens are produced in the testes. If you get a cortisol level between 5 to 15, so before I said low, what is low? Let's define it. Low is less than 5 micrograms per deciliter. If you get 5 to 15 micrograms per deciliter, this is an indeterminate result, okay? So what you want to follow that up with is a cosentropin test, 250 microgram cosentropin test. This is not going to allow you to differentiate between primary and central. What it is going to allow you to do is determine whether the indeterminate result that you got in cortisol is truly from adrenal insufficiency or not. If we see that there is no rise after giving cosentropin, then we know that is a primary adrenal insufficiency. If we see that there is a rise greater than 15, then we know that adrenal insufficiency is unlikely and we have to look for other causes to the symptoms the patient is presenting with. Let's review cerebral vein and venous sinus thrombosis. So clinical factors, or clinical features I should say, are headache, increased ICP, which will present itself with vomiting and papilledema. You may also see focal neurological deficits and seizures and overall encephalopathy. Now, what are the risk factors for developing cerebral vein and or venous sinus thrombosis? The risk factors are thrombophilia, pregnancy, postpartum, oral contraceptives, oral combined contraceptives, malignancy or infection, anything that can predispose somebody to developing clots. Now, what are you going to do if you suspect that somebody has this? The ideal diagnostic test to use is an MRI with MR venography. It has the most sensitivity. But the most available and the fastest test to do is a CT with CT venography. Another test that can help you is the D-dimer. D-dimer will be elevated. Treatment, low molecular weight heparin or heparin. I would like to do a quick review of D-dimer. So common causes of elevated D-dimer include thrombotic conditions. Let's talk about the physiology behind it. It's elevated whenever there's fibrin degradation, and fibrin degradation happens whenever there's clot formation and breakdown, right? Formation and breakdown. So thrombotic conditions, obviously DVT, PE, DIC, arterial thrombosis, less common in arterial thrombosis. Recent clot breakdown, so surgery, trauma, bleeding, hematoma, or in the postpartum period. Inflammation and infection, malignancy, liver disease, reduced clearance of D-dimer, okay? And liver disease in and of itself is also associated with altered coagulation. Pregnancy in the second to third trimesters. Advanced age, that's why there are age-adjusted cutoffs for the D-dimer level. And other conditions such as heart failure, stroke, or sickle cell crisis. Remember that D-dimer is very sensitive, but it's not specific. It's most useful for ruling out DVT and PE in low-risk patients, okay, in low-risk patients. If you have a high-risk patient, you're just going to go straight to imaging. I mentioned that D-dimer is not typically elevated in arterial thromboses. And the reason why is interesting. So in arterial clots, because of the environment that they're forming in, there's much higher shear stress going on. And so the reasons for arterial clots forming in the first place tend to be a little bit differently, okay? It's not usually because of the whole Virchow's triad, right, of For example, stasis in particular. We have stasis in the venous system, but in the arterial system, we don't. And so usually the precipitating event for clots forming in the arterial system has to do with some sort of epithelial dysfunction. And it's, like I said before, it's forming under high shear stress. Arterial clots tend to be platelet rich. So they have a high platelet content and they have a low fibrin content. Okay. Venous clots tend to be fibrin rich. Okay. Arterial thromboses tend to form locally and don't send off this systemic wide fibrin activation. Arterial thromboses tend to be smaller than the venous thrombi also. Think about like the clots that form MIs or strokes. They're small. But a DVT could be anywhere from all the way from your calf all the way up to your thigh into the femoral vein. Right? So because of that, D-dimer is not going to be elevated in arterial thromboses. When are the times that you do not use D-dimer? Well, like I mentioned earlier, if the clinical suspicion for PE or DVT is high because the patient is high risk, you're not going to use it. In post-op patients, in patients with recent significant trauma, in hospitalized inpatients, they typically have infection and inflammation or other comorbidities. It's going to be very nonspecific in that situation. Pregnant patients, like I mentioned earlier, patients with known inflammatory and infectious disease, such as pneumonia, sepsis, COVID-19, or autoimmune flare. Elderly patients, if you're not using the age-adjusted cutoff, and patients already on anticoagulation, the D-dimer will be false negative because it's already going to be low. So there's an interesting phenomenon that happens in women during the first few years of menarche. So it seems like the body is still learning how to tap into the monthly rhythm of menstruation. And so there will be some months where anovulation occurs and the whole cycle doesn't get to complete itself. And so because of this, the endometrium does not get sloughed off completely. There's not that sharp progesterone rise that triggers the sloughing of the endometrium. And so what happens is that they'll go from 1 month into the next with the same endometrium there, but then an estrogen uptick will cause a breakthrough bleed. And this is built up endometrium. So the menses is going to be heavy, right? And because, like I said, the body has not quite gotten into the monthly cycle yet, it's going to be a history of heavy, irregular menses, okay, in a young woman. So how do we treat this? First line therapy is going to be combined oral contraceptives with high dose estrogen. The estrogen is going to help proliferate the disordered endometrium and repair the bleeding sites. Now, if the patient is hemodynamically unstable, we skip that and we go straight to IV estrogen. If the IV estrogen fails, or for whatever reason there is a contraindication to IV estrogen, then we'll move towards a D&C. Now, what are some contraindications to IV estrogen therapy? We have absolute contraindications and relative contraindications. The absolute contraindications goes back to what we were talking before about thrombi. So if there's an active or history of thromboembolic disease, DVT, PE, or known thrombophilia, absolutely not. Active or recent arterial thromboembolic disease, such as stroke, MI, or unstable angina, absolutely not. Estrogen-dependent malignancy, breast cancer, endometrial cancer, absolutely not. If there's liver dysfunction or active liver disease, estrogen is metabolized in the liver and can worsen hepatic dysfunction, so we're not going to do it there. Pregnancy also, because pregnancy in and of itself is also increased thrombotic risk. And also the estrogen is going to screw with the hormones that we have going on in pregnancy, which are a nice, delicate balance. So we're not going to do that there. Or if there's a known hypersensitivity to estrogen products. Relative contraindications are high risk for venous thromboembolism, such as obesity, immobility, smoking, or family history of VTE. Migraine with aura. If you use estrogen, there's an increased stroke risk here. Uncontrolled hypertension. Again, increased stroke risk with estrogen exposure. Or if there's cardiac disease or congestive heart failure. I mentioned earlier in the particular case of the abnormal uterine bleeding from the anovulation during the first years of menses that we would move on to a DNC if the IV estrogen therapy doesn't work. Now, DNC in that's just the examination answer, right? But let's just talk a little bit about real life. So a DNC, this is a problem that affects young women. A DNC in a young woman is, you don't want to do that, right? She may still want to have children. You're going to kind of mess with the ability of her uterus to implant a placenta, okay? And can give her some high risk features for her pregnancy later on. So if we can help it, then maybe we can try something else. And there are other alternatives to IV estrogen, such as high dose IV oral progestin, such as medroxyprogesterone, tranexamic acid, high dose combined oral contraceptives, or mechanical tamponade, right? Now, that's just broad strokes for whenever you're using IV estrogen, okay? Now let's quickly review the PALM-COEIN algorithm for abnormal uterine bleeding in non-pregnant women. Structural causes are PALM, okay? Polyps, adenomyosis, leiomyoma, malignancy, and hyperplasia. Non-structural causes is COEIN, coagulopathy, ovulatory dysfunction, endometrial, such as infection or inflammation, iatrogenic, such as anticoagulants, and the last one, our favorite category, not yet classified. Brain death and organ viability. The patient is brain dead. They express the wish to donate their organs. What are we going to do? So, there are 3 factors that affect organ viability in a patient that is brain dead. The first one is central diabetes insipidus. The brain is dead. Hypothalamus is not responding to anything. There's going to be a major diuresis of greater than 1,000 milliliters per hour. Okay. The second thing is decreased sympathetic tone, which leads to hypotension. And then the third thing is hypothermia. So these 3 things we need to address in order to maintain the organs viable for harvest. What are these interventions we're going to do? We're going to do aggressive fluid resuscitation, and we're going to add on desmopressin on board. Remember that the mechanism of action of desmopressin is to bind to the V2 receptor and prevent release of water, preventing diuresis, right? And this is also the reason why we use desmopressin as a treatment for central diabetes insipidus. The next thing we're going to do is ionotropic or pressor support for the blood pressure and warm blankets. Ischemic stroke, thrombolytics, and blood pressure targets. Let's say you have somebody who came in with an ischemic stroke, you did the CT, you ruled out hemorrhage, you're considering to use alteplase, but the blood pressure is high, very high, okay? How high is very high? If it is above 185 over 110, it's too high for thrombolysis, okay? So what you need to do first before you administer thrombolytics, use a fast-acting titratable IV antihypertensive such as nicotine. trade name Cardine IV. You want to get the blood pressure below 185/110. Once you achieve that point, right, then you can go ahead and administer the thrombolytics. After the thrombolytics have been administered, remember that we want to allow permissive hypertension. So we're going to allow the blood pressure to ride anywhere below 180/105 for the first 24 hours. Let's say before the thrombolysis that the patient's blood pressure was greater than 220/120. In this instance, it's too high to even consider thrombolytics and it's contraindicated. What we're going to do in this situation is, again, allow permissive hypertension, but that hypertension of 220/120 is too extreme. So we're going to lower it, but we're going to lower it at a specific rate. We're going to lower it by about 15% within the first 24 hours. If for whatever reason you manage to get it to 185/110, starting at that 220/120, you manage to get it to 185/110 within the 4.5 hour window of thrombolysis, then sure, go ahead. Okay. Let's talk about thrombolytics. There's alteplase, which is the most commonly used one, also known as, trade name is Activase. Then we have two other options, which are tenecteplase and reteplase. But these are FDA approved for myocardial infarction, and they have a longer half-life. Then there's also streptokinase, not really used in the United States, used overseas. It's cheaper, also can have some adverse reactions to it. Now, the 4.5 hour window, why is that a thing with thrombolytics? Studies have shown, large trials have shown that over 4.5 hours, the risk of thrombolysis converting to hemorrhage is higher than the benefit. At that point, there's less viable penumbra available. However, there are people that are known as slow progressors, which may still have viable penumbra available 6 to 12 hours after symptom onset. How can we tell if somebody's a slow progressor or not if they have viable penumbra? We use advanced imaging such as CT perfusion scans or MRI using DWI flare. And we're going to look for DWI flare mismatch. So in those select cases, we can still consider using thrombolysis after the 4.5 hour mark, but it's typically not done. If we pass the 4.5 hour mark, another thing that we can consider within the first 24 hours is mechanical thrombectomy. Okay. And the reason for this is because the thrombolysis breaks down using the clot busters, right? The thrombolytics, it breaks down the protective fibrin in damaged blood vessels. And this is what increases the conversion to hemorrhage. But mechanical thrombectomy is not using that systemic anticoagulation, right? So it's not going to break down any fibrin. You can use it within the first 24 hours if there is still salvageable penumbra based on advanced diagnostic imaging. Why 24 hours? Most people, again, large clinical trials, most people, almost everybody really, after 24 hours, no viable penumbra. We may be asked to identify a study design based on the description given of the study. And so let's talk about a way to identify study designs based on their temporality. So if we look at now versus the past and the future. So let's talk about clinical trials. Clinical trials are going to compare two groups, the treatment group versus the control group, and we're looking towards the future for an outcome of interest. Prospective cohorts are starting in the now, looking at positive risk group versus a negative risk group in the now. And we're looking towards the future for disease incidence. That's a prospective cohort. Next, we have a retrospective cohort, which looks into the past for positive risk factors versus negative risk factors, and we'll look at the now for disease incidence. Or we'll look at a period of time, I should say, between then and now for disease incidence. That's retrospective cohort. Then we have case control studies, which are looking at the now in terms of disease cases versus controls. But then we look towards the past to look for risk frequency. Next, we have cross-sectional studies, which look at the now for positive risk factors versus negative risk factors, and also look to the now for disease prevalence. And that is a cross-sectional study. So you can see both clinical trials and prospective cohorts look towards the future. Retrospective cohorts look towards the past. Case control starts now and looks to the past. And cross-sectional begins now and ends now. If a child swallows a battery, we want to remove it endoscopically immediately if it's still in the esophagus. If it has proceeded beyond the esophagus to the stomach or intestines, we're going to observe very carefully. If we see symptoms of abdominal pain or hematemesis, then we are ready to immediately intervene surgically. Right, so how do we recognize cryptococcal meningoencephalitis? So this is going to manifest in people who have a CD4 count less than 100. So we're going to have some risk factors for HIV. And it sets on with an initial 2 weeks of fever, lethargy, and headache, non-specific symptoms, but then will progress to having blurred vision and papilledema. You're going to do a CT scan. CT scan is negative. It is also common to find papular lesions on the patient. Papular lesions with central umbilication, which is reminiscent of molluscum contagiosum, but it's not molluscum contagiosum, it's Cryptococcus. Then you're going to do a lumbar puncture. Once a CT scan is negative, you're going to do a lumbar puncture, and you're going to see that the opening pressure is fairly high. Fairly high means greater than 250 millimeters of water. There is a low leukocyte count in the CSF with a lymphocyte predominance, lymphocyte predominance, high protein and low glucose. This is all telling you you have a fungal infection in the CSF. How are you going to treat this? You're going to treat this with amphotericin B and flucytosine. Now, there's something you have to watch for post-treatment, okay? What you need to watch for is increased intracranial pressure, okay? The reason why this happens is because in this kind of infection, there's a very high fungal burden of greater than 1 million yeast cells per cubic millimeter. This high fungal burden makes it so that the particulate matter, right, the protein capsules and all the cells clog up the arachnoid villi, so there's going to be no drainage of CSF. Therefore, you have the increased ICP, and then you have this recurrent symptomatology of headaches, vomiting, visual changes, papilledema, and or cranial nerve palsies. What's the treatment for that? You're going to relieve the pressure by doing serial lumbar punctures until the symptoms resolve. Now, for cryptococcal meningoencephalitis, there is a whole treatment, right? The initial treatment we gave was amphotericin B and flucytosine, but there is going to be a treatment that can last for greater than 1 year. And it takes place in 3 phases. They are induction, consolidation, and maintenance. In the induction phase, we give the amphotericin B plus flucytosine for greater than or equal to 2 weeks until the symptoms are gone and the CSF is clear. Okay, there's nothing growing on the CSF. Second is consolidation. After we have symptoms resolve and the CSF is clear, we give oral fluconazole, high dose oral fluconazole for 8 weeks. After that, we do maintenance, which is low dose fluconazole for greater than or equal to 1 year. Scoliosis is commonly idiopathic. However, there are some rare instances in which scoliosis can be a complication of spinal pathology, life-threatening spinal pathology. And so there are certain red flags that we need to look out for whenever we are evaluating a patient with scoliosis. These red flags are back pain, neurologic symptoms, a rapidly progressing curvature of greater than 10 degrees per year, and vertebral anomalies on X-ray. The gold standard would be doing an MRI of the spine to rule out any spinal pathology. When it comes to helping someone quit nicotine, okay, there are multiple treatment options available. So all treatment options are going to include some combination of behavioral therapy plus some pharmacology, okay? And the go-to pharmacology is nicotine replacement therapy. So you could either use long-acting nicotine replacement, such as a nicotine patch, or you can use short-acting nicotine replacement, such as a nasal spray, a gum, a lozenge, or an inhaler. Using a combination of these two has the best efficacy. Okay, so you could combine long-acting and the patch plus, right? So the patch plus or short-acting nicotine replacement in addition to the behavioral therapy. It's safe in almost all patients, no significant adverse effects, and will decrease cravings and daytime withdrawal symptoms. What are withdrawal symptoms of nicotine cessation? Restlessness, anxiety, irritability, decreased concentration, insomnia, and depressed mood. These cravings are the biggest reason why people relapse. Now, in addition to nicotine replacement therapy, we also have varenicline and bupropion. Bupropion is good for decreasing post-cessation weight gain, which some people might be concerned about. It's also a good choice for patients with unipolar depression. However, remember that bupropion decreases the seizure threshold and can also bring about eating disorders or previous eating disorders. So it is contraindicated in patients with seizure or eating disorders. The other option, varenicline, is more effective than bupropion or nicotine replacement therapy. However, the adverse effects of this are disordered sleep and abnormal dreams. The Organ Procurement and Transplant Network has made a list of contraindications to donation. So let's go through the list. Contraindications to kidney donation: age less than 18, lack of mental ability to make an informed decision, uncontrolled hypertension, HIV infection, or diabetes, active or partially treated cancer, acute infection, high suspicion of donor coercion, high suspicion of illegal financial exchange from recipient to donor, uncontrolled psychiatric illness, and active substance abuse. So the person could have been a former substance abuser. They could have had a psychiatric illness in the past that is now controlled. But if there's any suspicion of some sort of coercion or financial exchange from recipient to donor, then you cannot donate that kidney. A p-value of 0.01 tells you there is a 1% chance that the null hypothesis is true. A p-value of 0.02 tells you that there is a 2% chance of the null hypothesis being true. Confidence intervals and their relations to p-value. If your confidence interval, all right, let's say you're dealing with relative risk and odds ratios, and your confidence interval is including 1. If it includes 1, remember that a confidence interval of 1, right, if we're basing it on relative risk and odds ratios, means there is no association. This would indicate that the p-value is greater than 0.05. So the null hypothesis is accepted. If your confidence interval is anywhere in the range below 1 or greater than 1, in other words, it does not include 1, then that means that the data you've been given is statistically significant and the p-value is less than 0.05. Another thing I want you to consider is that the confidence interval calculation includes sample size in the denominator, which means that a smaller or a tighter confidence interval indicates a higher sample size.